Hello friends, my name is Dr. Nayyar Kasmi. Welcome to my YouTube channel. And today I'm going to talk about a very important topic in pediatric emergency medicine, and that is the topic of pediatric trauma. So very now and then, on an occasional basis, we do get a case in our clinical areas where somebody who has been drowned either in his bathtub or in a bucket or maybe in a swimming pool, they usually present either asymptomatic or with mild symptoms. So I take this opportunity to discuss in detail the very important topic of pediatric drowning. So let me go through the overview of this lecture. So in the coming few minutes, I would start with some background statistics regarding the morbidity of pediatric drowning in UK and worldwide. I would be talking about the pathophysiology of drowning. I'll be talking about the pediatric emergency medicine management of such cases. We would be looking at some long-term issues. And last but not the least, I will illustrate all these things with the help of a case study. So let's start. So in UK, annually, the number of deaths caused by drowning is around 400. And this data comes from the last 3 to 4 years. So over 2015 to 2018, consistently around 400 deaths have been recorded every year, which were attributed to drowning. Now, 45% of these deaths were caused by recreational activities. It means that the deaths due to drowning was caused by some form of recreational activities, like somebody was doing diving, or somebody was doing swimming pool, or was taking swimming pool lessons, or somebody was walking around along the beach, fell into the water, fell into a ditch, water ditch, or a water pond, or somebody was doing like some sort of sports like jet skiing or water sports, things like that. Of these, 44% didn't plan to enter the water. So they were either on the boat with their families, probably without the life jackets, or they were just like walking around the river, taking a walk, or just like going on some form of a bridge with no sort of fences on the side and accidentally fell into the river. While 5% of the deaths have been attributed to bathing. So these 5% of the deaths were caused when a child, usually these were pediatric deaths, they were caused by submersion. So either the child went into the head was submerged below the water surface, or they had some underlying problem like seizure. They had a seizure activity because of which they actually drowned in the bathtub, or small babies, they fell head down into the buckets, not able to push their heads up, and were eventually drowned. And one of our colleagues, our former health secretary here in UK, Jeremy Hunt, his sister actually died because of drowning in a bucket, and he still has memory of that. Probably in one of the interviews, he said that he was around 2.5 years of age when one of his nanny was actually, they were bathing the brother and the sister. The sister was at that time was around 1.5 years, and they both were in the water tub, and he remembered that all of a sudden she went inside and then she was not responding. And when the nanny came up and she was face up in the water, she was attended by the paramedics, but she didn't make it and eventually died. So that's another one of significant cause of drowning, that going somebody taking a bath and had getting accidentally immersed below the surface of the water. I will not be taking into consideration the 200 additional suicide fatalities. Now, these are cases caused by drownings, but these have been, the reason behind them was suicidal. So these were the cases where usually teenagers or a mentally deranged person, they jumped from the river, or jumped from the bridge, or they accidentally, they deliberately jumped into a pool of water, or they jumped from a boat and deliberately drowned themselves and eventually died as the reason of drowning. We have also seen that there is a bit of underreporting of drowning, even because many times child can usually get some immersion in the water or submersion for a few moments, and they get a bout of choking and coughing, and they are fine after that. And the parents think that, okay, fine, the child has been fine and he's been doing well, so they don't bring them to the hospital. So these types of cases, they usually go underreported. And globally, around 3,700 cases, they die annually because of drowning. Majority of these cases, they occur in the developing countries. So I would say around 80% of these uh, cases, they occur in developing countries. And again, it's because of the reason that probably the laws are such that probably the water ponds, the lakes, or water reservoirs are not properly fenced, or not properly guarded, or properly watched by lifeguards. So usually the number of cases are more in developing countries. So this was a bit of background about of drowning. And again, as far as the ages is concerned, the high risk groups are usually the pediatric population. So if we see uh, within pediatric population, children between 1 to 5 years of age, most of them, they are the one who are usually get drowned. Or then we see another peak in the adolescent years, like 15, 16, 17 years of age, where either because they are taking drugs, or if they've got an underlying acute, like underlying problem like seizure, they are more prone to drown. Worldwide, 81% of those who are drowned are male, and there is only equals in 90 plus age group. So above 90 years of age, then male and female is equal. Again, old age people, because of the associated problems like dementia or something, frailty, they are more prone to have weak systems to comprehend if there is some sort of danger, water danger around them. They can get submerged in their bathtubs. They can even fall in the rivers, in water ponds, and can die as a result of that. And the results are consistent throughout the world. I mean, almost all the countries, if you look at the data, so it's more or less the same data. So globally, 50% of the cases who really die because of drowning, they are in the age group 0 to 25 years. So mostly young age group. And again, I said between 0 to 25, most of them are 1 to 5 years of age. The toddlers, the infants, which have got more predisposition to become a victim of drowning. And then the adolescent age group, where because of the underlying risk-taking behaviors, they are more susceptible to get drowned if they are in a sort of in some form of water activity. As far as the United Kingdom is concerned, it fares well on international ranking because annually the number of cases is 400 accidental drownings with 200 suicidal drownings. So on international ranking, it's doing better as compared to other countries. Now coming down to the pathophysiology. So I want to take a few moments to discuss what happens when somebody gets drowned. So the definition of drowning these days, the latest definition is that is defined as respiratory impairment due to immersion or submersion in any liquid. So most of the time this liquid is water, but this could be any liquid. And again, it could be either immersion or submersion. Submersion means that the body, the head, the whole thing, it goes beneath the level of the water. While immersion means that the face is splashed with water. So momentarily the face interface, it touches the water, and a little bit of water can go inside the mouth and nasal cavity, and probably can go into the airways as well. While submersion is complete, where the whole head is below the level of the water. We had old definitions of dry drowning, wet drowning, and near drownings. All these definitions are obsolete now. They are no more used in new textbooks. So all these new definitions have discarded all these classification of wet and dry and near drowning. So at the moment, there is just one definition of drowning, and that is simply that it is respiratory impairment. So any form of respiratory impairment due to immersion or submersion in any form of liquid. Most of the time, this is water. And this water could be in the bucket, this could be in your bathtub, this could be in the river, this could be in the pond, this could be in the lake, this could be in the ocean, or this could be any other form of liquids as well, though they are quite rare. What happens when somebody gets immersed or submerged below the surface of the water? So what happens is that the water, whether it's fresh water or salt water, it goes through the nasal cavity or through the mouth and touches the entry to the airways. Now, the entry to the airways, the larynx and the trachea, they are very sensitive. So as soon as the water touches it, it leads to severe what we call as laryngospasm. This laryngospasm is so severe that it temporarily blocks the airway. So when the airways are blocked, this leads to complete anoxia because there is no way now you can take breath. And this is a protective mechanism, basically. The body tries to protect further entry of water into the airways by actually inciting a very severe laryngospasm. So this laryngospasm would lead to buildup of carbon dioxide in the body. At the same time, the oxygen level would go down. So there would be hypoxemia and increase in carbon dioxide levels. Now, if the person comes out of the water and he breathes out, so this can be relieved. But let's say the person cannot make it, the head still remains submerged in the water. So this laryngospasm would remain for some time. And please keep it in mind that the brain has got a reserve of around 5 minutes. So for the 5 minutes, the brain doesn't get oxygen, the neurons would start going haywire, and that can lead to a lot of trouble. So if this laryngospasm is not relieved because the person hasn't come out of the water or something, so what would happen is that this laryngospasm will go away, and then there would be a voluntary involuntary intake of air. So this intake of water, and this water can go into the airways as well as can go into the lungs. Normally, there is a sort of a misconception. People think that a lot of water goes in the lungs. Now, normally, this is not the case. Usually, not more than 4 to 6 mils of per kg of water can enter the lungs. It's mostly the person swallows, and most of the water goes into the stomach. So the gastrointestinal system, stomach is quite filled with water. So a lot of water goes inside into the stomach as well. Water goes into the airways as well. So obviously, when it goes down the airways, it will go down the bronchi and would reach the alveoli. And there, what happens? Let's say, I mean, here again, the pathophysiology slightly differs. Somebody is submerged in, let's say, salt water, that is ocean or sea water, which has got high salt content. So what would happen is that if I draw the diagram of the alveoli, and let's say there is water here. This water has got high sodium content. When there is high sodium content, what would happen? The water from the interstitial spaces and from the blood vessels, this would be drawn into the alveoli. So the alveoli would get full of water. And this would lead to alveolar distension with fluid. This would lead to what we call as ARDS, acute respiratory distress syndrome. So there will be a lot of water inside the alveoli. The alveoli would be full of water. And when the alveoli would be full of water, there will be not enough surface for gas exchange. Even if the person comes out of the water and the lungs are filled with this water, so even if that person is breathing, you're trying to give him oxygen, ventilate him, what would happen is because of the air, the surface area where the gases exchange takes place, that is full of water. So the gases exchange cannot happen, and the hypoxemia and anoxia would actually aggravate, and that can lead to a lot of problems because that would lead to multi-organ damage, that would lead to hypoxia, ischemic encephalopathy, it can lead to multi-organ damage, etc., etc. So if there is a lot of fresh water into the alveoli, the water would go into the alveoli and called ARDS. Now, on the other hand, if it is fresh water is isotonic. So if I go back over here and let me draw. And let's say this is isotonic. So because this is isotonic, what would happen? It would enter the circulation. So when it would enter the circulation, this would cause dilution of the blood, and the electrolyte levels can fall down, and that can lead to further problem, and that can lead to circulatory overload, and that can lead to heart failure and so on. So these are the two types of differences in saltwater drowning and in freshwater drowning. Now, in both cases, the other thing in freshwater drowning is because the fresh water is coming up, what would it do? This fresh water would actually sweep away the surfactant level inside the surfactant, which is actually lining the inner linings of the alveoli. And you know, the surfactant is basically responsible for surface tension, which is responsible for keeping the alveoli open. when this water comes and it washes the surfactant, so what would happen? The surface tension would increase and the alveoli would collapse. When the alveoli would collapse, what would happen? This is what we call as atelectasis. So when there will be atelectasis, there will be VQ mismatch, because the blood which is coming to that particular area through the pulmonary vessel, that will not be able to pick up oxygen because those alveoli are collapsed and are not taking part in gaseous exchange. So the blood would contain less oxygen. So there will be less oxygen and more carbon dioxide. So ultimately, the end result of all this, whether this is freshwater drowning or whether this is saltwater drowning, is hypoxia. So less oxygen leading to less oxygen in the blood, hypoxemia, and this hypoxemia leads to injury, cellular injury. And this cellular injury in the initial stages can be reversible, but there is a fine line dividing between reversible, irreversible. If it crosses that line and goes into the irreversible stage, first thing to get hit is your brain. So the brain can get irreversible hypoxic ischemic encephalopathy or injury, and it can die because of that. At the same time, different organs, your vital organs, heart, kidneys, liver, if they're not getting enough oxygen, they would start getting necrosed, and this would lead to multi-organ failure. And this multi-organ failure can be a challenge even if that person is rescued. If that child is rescued and is taken to emergency department, or that child is taken to a pediatric intensive care unit, still it becomes very challenging for the intensivist, because once a multi-organ damage it sets in, it's very difficult to rescue these children, and they eventually die. That's why the mortality is very high. If for some reason there is extensive irreversible damage. So a little bit about this was about the pathophysiology of drowning. Moving onward, what are the issues? Like when somebody gets drowned, and obviously the head is below the water, water enters the airways. So there are airways issues, there are issues with breathing, there are issues with the heart, there are issues with C-spine, especially if somebody is has dived from a height and landed with head down into a pool or into a lake, can get C-spine injuries. There's issues with hypothermia as the body loses temperature beneath the level of the water. And then later on, there are issues with secondary infection. The airway issue, we know that initially it is laryngospasm, and in other words, the airways are blocked, especially if there is thick gunk in the air or there is water in the airways. So there would be an airway issue. Breathing is always an issue, because if there is a damage at the alveolar level, if there is fluid at the alveolar level, so gaseous exchange cannot happen, and these people would be having, if you do sets of these children, the sets would be low, and it's simply because the gaseous exchange is not very effective. They can have cardiac issues, because I told you that hypoxia can cause cardiac injury, and cardiac contractility can be compromised, and cardiac contractility can compromise, you can know that can lead to devastating effects on all the organs of the body. Neurological issues, because hypoxic ischemic encephalopathy, I told you that the brain has got a 5 minutes reserve of oxygen. For 5 minutes it doesn't get it, the neurons start dying. And if there is extensive damage, global damage to the neurons in the brain, then the child cannot be rescued. Even if they are rescued, long-term neurological sequelae would be very bad. Issues with C-spine, especially those who've got a low GCS, especially if the history is not clear, or if they have fallen from a height into, let's say, a reservoir of water or a pool or a pond, then you always have to consider injuries as well. And the most important, they could have multiple injuries, like have fractures as well. But the most important thing is C-spine, because C-spine injuries can kill a child. There's issues with hypothermia as well, because usually in UK and in Northern Hemisphere, the water temperature, the open water temperature is always low. So if the child is immersed, they would start losing body heat, and as the body starts losing heat, the metabolic activities they go slow. There are more chances of cellular injury, and they can die because of that. So hypothermia is a big issue. Even when they are rescued, the water temperature has to be brought up, and that is a sort of a challenge in itself. And those who have survived secondary infections, because especially in those who have fallen in ponds or in dirty water reservoirs, they can have bacteria, And though in the initial stages, it's not much of an issue, but later on, secondary infections can become a big issue. Most of the bacteria that cause secondary infections are Aeromonas, Pseudomonas, Burkholderia, and Chromobacterium. So these are some of the common bacteria, and they are quite. They can be covered by tazocine, piperacillin, tazobactam combination, and that's one of the things that we use in those children who show secondary infection. These are some of the medical issues in drowning. Uh, Coming down to management. Now, management always starts at the pre-hospital level, and the pre-hospital level is the most important thing, because if pre-hospital care is good, there are more chances of survival. And if the pre-hospital care is not good, no matter how good care you give them in the ED or in the pediatric intensive care unit, mortality is still very high. So the pre-hospital care, as I said earlier, is the biggest factor in survival and recovery. If the paramedics have been there on scene, they did their level best. They took the child quickly out of the water and things, then the recovery can be quite good. So the other factors in pre-hospital care are minimizing submersion time. So if it is, let's say, if there were lifeguards on scene, or if the paramedics arrive on scene and they are, or even like those people who are trained and they are present in the vicinity of the drowning scene, and they can rescue the child. So that is, if they minimize that thing, that goes a long way in the long-term recovery of these children. Early resuscitative efforts are very important. So on-scene CPR, if the child is in cardiopulmonary arrest, is very important. The longer it takes for somebody to be given CPR, if they need it, leads to more mortality. And again, when we talk about resuscitation, we usually mean the ABC approach of the APLS algorithms. This is about pre-hospital care. Now, once they are in the hospital, in the emergency medicine department, in our pediatric medicine emergency. So again, we always start in A, B, C, D, E manner. So the first thing, as we would do in any emergency case, is looking after the airways. So if the child has got no GCS, he's not responsive, and the history not clear, it's very important that while we are taking care of the airway, we should always look for cervical injury, and usually they would require some form of cervical spine support till it can be ruled out later by doing a CT scan. At the same time, oxygenation is very important. You have to start oxygen. All those who had required resuscitation, they should always be put on 100% oxygen when they arrive in the emergency department. If they were intubated, it should always be a cuff ET tube, because usually they've got water in their stomach as well. And later on, when they vomit, there is always a risk of aspiration. So it's very important that when we are using an ET tube, and if they have been intubated, that should be a cuff tube. As far as the breathing is concerned, if they have been put on a mechanical ventilator, it's very important that we go for what we call as lung protective strategy. So lung protective strategy means two things. Number one, we should be using low tidal volumes. So low tidal volumes mean that in the case of a child, we should be using 4 to 6 mils per kg of tidal volume. And that you can multiply it by whatever is the body weight of the child, and you can give it per breath. The other thing is to use a high PEEP. PEEP stands for positive end expiratory pressure, and we have to use high PEEP. So usually we know that PEEP start from 5, but in these cases we have to go for a high PEEP. So we're going for something from 8 or 10 or sometimes even 12 centimeters of water. As far as circulation is concerned, we have to maintain age-appropriate mean arterial pressure, and for that we can use 50% of the maintenance fluids or emergency fluids, and at the same time, if needed, inotropes can be used to maintain the blood pressure. As far as the hypothermia is concerned, most of these kids, when they're brought to emergency, they're quite hypothermic. And we know that in hypothermia, especially if the temperature is below 33 degrees Celsius, some books say even to 32 degrees Celsius, we have to change in the resus drugs. So the dosages are different, so we have to use the different dosages. And at the same time, we have to go for rewarming strategies. So again, we know that there are two types of rewarm. We have to rewarm from inside and from outside. From outside, we can go for air hugging blankets, warm blankets. from inner, we can use the warm saline infusion to increase the core temperature. Neuroprotection is also very important. As I said earlier, C-spine protection is part of that neuroprotection. And if they've been intubated, so we have to keep it in such a way that the neuronal damage is kept to minimum. Though whatever has been done has been done. Whatever damage was done initially by the hypoxic injury, but you try to minimize, because it's sort of a cascade. If you don't stop it, then it could go in a vicious cycle, and the child will eventually die. Seizure control is not a routine thing, but you will control seizure as any other seizure, depending on the underlying conditions. And if needed, you can go for seizure controls as well. Antibiotics are not routinely used unless and until there's a clear indication. So if the chest X-ray shows sort of a patchy infiltration and atelectasis, some of the centers, depending on the local policy, would just give them broad spectrum antibiotics to prevent any secondary bacterial infection. Some would simply wait, and because usually if there is infection, it usually comes late, probably after third or fourth day. So if there is rise in temperature and the chest shows new shadows, consolidation, then antibiotics can be used, and you have to follow your trust guidelines for using the antibiotics. This is the algorithm which actually is used for any drowning case. So again, as it always starts at the pre-hospital level. So as I said earlier, that at the pre-hospital level, it's very important that the paramedics or the rescue services, they are well trained in how to do CPR. They have to transport all the patients or give oxygen to all the patients of who have been who are the victims of drowning, and they have to bring them to hospital as soon as possible. Now, once they are in the emergency department, whether they are adults or whether they are pediatric cases, I'm focusing more on the pediatric cases. Once they are in the pediatric emergency medicine department, again, we have to go through our usual A, B, C, D, E drills. We start with airways, we look for breathing issues, we look for circulation, we look for disability, and for exposure like temperature and etc., and we manage them accordingly. Now, in this, once they're in the hospital, it's very important that we look at two parameters. So either we can look at their GCS scores. Now, since GCS is a bit difficult to do in kids, so we use the AVPU score. So AVPU scores can correspond to various levels on the GCS. So if somebody is scoring A on a VPU scale, so the GCS could be anywhere between 13, 14, and 15. If they are responding to vocal stimuli, if they go on the V scale, then the GCS is 12. And if it is the P, then the GCS is 8, and U means obviously less than 8. So if the GCS is less than 30, let's say, it means if the GC, if they are scoring, if they are responding on vocal stimuli, or the O2 sets are less than 95%. So it's very important that the first thing in emergency is to clear the cervical spine. So you have to look for, if they are, obviously if they if the GCS is below the 30, you cannot do it manually, so you have to do a CT scan to look. So you have to give them supplemental oxygen. You have to consider endotracheal intubation if you think that the child is deteriorating and the hemodynamic parameters are going down. You have to do some ancillary tests, which includes chest X-ray, to see what is the condition of the lungs, whether you find any lactases or whether you find changes consistent with ARDS. You will do a complete blood count with UNEs, glucose, drop to see myocardial injury. You will do the QAG profile, urine analysis, creatinine kinase, urine myoglobin, and urine drug screening. Urine drug screening is also very important because in teenagers, they might have taken some drugs and they might get into the infest with the drugs like cocaine or any other spice and things like that. And because of that, they might have accidentally fallen into the water reservoir. That's why you should also be monitoring consistently acid-base status, which is very important. You should be monitoring the temperature, the volume, input, output, and CVP if you have faster symptom in the sign. So this is for those kids who have got a GCS less than 13. So in other words, if they are scoring V on APVU scale or their sets are less than 95%, then Number one, you have to clear the cervical spine. And again, you have to do a CT for that. Number two, you have to give them 100% oxygen. You have to do ancillary tests, and you have to intubate if needed, and do whatever you can do in order to, to give them hemodynamic support. That would mean the use of inotropes if needed, and fluids, etc., antibiotic if needed. If the GCS is equal or greater than 30, so if this child is on the A scale and the O2 sets are greater than or equivalent to 95, that is the thing. Then number one, you have to clear cervical spine. Again, it would depend if the child is alert, obviously in this case. So you look for any cervical spine tenderness, and if there's no tenderness, you clear the cervical spine. You would monitor the oxygen sets for at least 4 to 6 hours. And in this case, ancillary tests like chest X-ray, blood tests, etc., they are not indicated to begin with. But let's say if the child deteriorates, then you will go with this side. So child, you observe them for 4 to 6 hours. If they are deteriorating, you go toward this side. If they are stable, if they are maintaining their sats, the GCS is consistently above 30, then you can discharge them with giving them advice that in case if there is any trouble, if there is any late symptoms like temperature or cough or difficulty in breathing, they have to come back. So you have to give some form of safety netting. Either you can call them to come back within 48 to 72 hours, or you can simply tell them to contact a healthcare provider who can do an assessment of 48 to 72 hours to see if everything is going fine. And you also, at the same time, you explain the red flags to them and say, okay, if there is any red flag, you come back immediately. Okay. Now, the long-term issues are that, remember that those victims who require CPR at the scene. So if somebody was drowned and he was taken out of the water and he needed CPR on site, so somebody did a CPR, now they have a very good prognosis, because research has shown that among all those children who got drowned, were rescued and were given CPR there at the scene, 20% of them, they die later in the hospital, either in the emergency department or in the intensive care. And of those who survive, 5% are left with severe hypoxic ischemic encephalopathy. So they are, they've got mental, they've got like a problem with the neurological system for the rest of their life. Now, those who either required CPR at the site or they required CPR in the emergency department, they've got a very poor prognosis. Most of them, they die. So they say that those who had asystole and then they had, they can have some complete or near complete neurological recovery, especially if they fell in icy water. There have been some studies that have shown that people have survived, but again, such occurrences are quite rare. So it's not the norm. It's very rare. It would be sort of a miracle if somebody had a, let's say, cardiac arrest and comes out of that, and then he's fine for the rest of the life without any long-term complications. Okay, so having said that, I will try to illustrate with that case study, and probably this would, clarify the pediatric drowning in more detail to you people. This was an 18-month-old baby, boys basically, and he was at a family gathering with multiple other children at his uncle's house, and his uncle's house had a pond in the back garden. So the kids were playing around. The elders were having a chit chat with one another, and as you know, the kids are running around, and one of this child, the mom noticed that he was missing. So she asked the other kids. Nobody knew where he was. So they started, calling his name and looking for him. They couldn't find him in the house. They went upstairs, they went downstairs, they went outside. They couldn't find him. So they become very much stressed. They become very much panicked, and they start screaming. And they eventually went to the back garden. There they found that he was face down in the garden pond, unconscious. Mom was screaming and frantically screaming. So 999 was called. One of the household member, because he knew how to do CPR, so he took the child out of the pond, laying down on his back on the grass and started CPR. So the paramedics they arrived within 7 minutes on scene. They found that this 18 months old was in cardiorespiratory arrest. So they found there was no breathing, there was no pulse. So as the uncle was already doing CPR, so they took over. They started doing CPR, and after 2 cycles of continuous CPR, return of spontaneous circulation was established. In the meantime, the paramedics also called the HEMS. The HEMS stand for Helicopter Emergency Medical Services. So the HEMS, they also arrived on scene, and because of the condition, they intubated and ventilated the baby on scene. And the HEMS doctors, when he was intubating the child, he noted that the air walls were quite soiled, quite dirty, water inside the airways. So this child was, after intubated and ventilated, this boy was lifted by the air ambulance helicopter, was taken to the pediatric emergency medicine department. So because the call was placed in the trauma team, already ready on arrival, so they again went through their ABCDE drill. So airways was secured already by a size 4 cuffed endotracheal tube. On arrival to the pediatric emergency medicine department, they found out that he had bilateral air entry on both lung, but he had coarse crackles on the left lung base as well. Capillary refill time was less than 2 seconds, and the HEMS had already given him a fluid bolus of 20 mils per kg of normal saline. Because he was intubated, he was already paralyzed. His pupils on both sides were 4 millimeter, and they were quite sluggish. They were reacting to light, but they were very sluggish. When doing the E, that looking for exposure, they didn't find any sign of external injury, but his body temperature was 3 degrees Celsius. So a blood gas was done, and the blood gas showed and the pH of 6.8, the PCO2 was 9.6, PO2 was 15.2, bicarbonate was 7.3, base excess deficit was minus 21, lactate was 13. So here, if you look at the blood gas picture, it shows a mixed respiratory and metabolic acidosis. Lactate was quite high. The PO2 oxygen was quite high. Already he was on 100% oxygen. That's why you are seeing more oxygen values. But obviously, look at the pH. So he was severely acidotic, and you can see the values high PCO2 with a low bicarbonate simply mean that this is mixed acidosis, so mixed respiratory plus metabolic acidosis. So already a lot of damage set in. So this child, after being given emergency treatment, was admitted to pediatric intensive care unit. So he was started on conventional ventilation, and the parameters were that he was put on the VNAT airway pressure was 27, so it was a bit high. A high PEEP was kept, that was the 10 centimeter of water. But the good thing he required little FiOs too. So his FiO2 was 25%. He was on 25% oxygen, and his sats with all these parameters is like 27 MAP and 10 PEEP was around 92%. An arterial line and central venous line were also inserted to do blood gas around the clock and give central fluids and inotropes as needed. Neuroprotective measures were also put in place. He had later had some hyponatremia. The sodium was low, so the sodium infusion was also commenced to practice electrolyte imbalance. If you look at his further PICU course, day 1 to day 4 was fraught with different system-based challenges. So like he had issues with his heart, he had issues with his liver, he had issues with his brain, he had issues with his kidneys. So there was a lot of challenges to maintain good renal blood flow, maintain blood pressure, maintain good cardiac output, maintaining the liver function as well. So they found that he was persistently tachycardic, like despite being given inotropes and being given fluid resuscitation and doing all those things, he was persistently tachycardic. The blood pressure was quite fluctuant, and that's why they had to give them inotropes in and inotropes out, and this went on for a few cycles in the first 4 days. He had also temperature instability, so the temperature was very fluctuant, so it was going up and down, and he had issues with electrolytes as well. So if you look at all these things like persistently tachycardic, fluctuant BP, temperature instability, so this simply shows that he has a lot of autonomic instability. And probably these things also happen when you've got multi-organ failure. So multi-organ failure with autonomic instability because of widespread neuronal damage can give you this condition, because very often when we come across those people who had severe, those children who had a severe multi-organ damage, we find more or less a similar picture. Later on day 5 to 8, his course was the CT head was done, followed by an MRI, and it showed hypoxic ischemic encephalopathy changes. So here, if you see, this is his CT scan, and you can see that the differentiation between gray and white matter is quite blurred. You can't actually differentiate it very clearly, and this is one of the signs of hypoxic encephalopathy. So because of profound neuronal damage and neuronal necrosis, you can see that this differentiation gone. There's a lot of edema as well. So they also found out that the brainstem was affected. He had an ongoing multi-organ failure, so his liver was failing. He had a high liver enzymes. His kidneys were shutting down. Brain was already damaged quite, and then the heart was also giving way. So they gave him a trial of spontaneous breathing of extubation, but there was no respiratory effort, and unfortunately, there was not much for this boy, and he ended on a very sad course. So he eventually died on day 8. So this simply shows that once if multiple organs are damaged because of drowning, so that leads to a very poor prognosis. Despite the fact that you can give them the best of treatment, the best of intensive care units, still the outcome is quite poor. So most of them, they die, and even if they don't die with this type of CT head, even if this child would have survived, you would have well imagined what would be the outcome for the rest of his life. He would be almost paralyzed for the rest of his life. So the prognostic factors which decides what will be the outcome in any drowning case. The worst prognostic factor is number one is need for bystander CPR at scene. So if somebody needed a CPR, cardiopulmonary resuscitation at scene, that is a bad prognostic sign. So these people would do develop some complications, and they simply mean that the outcome would not be good for those people. If they needed CPR in the ED, irrespective whether they needed CPR or not, no CPR at the scene, that's also a bad prognostic factor. Or if they had a cardiac arrest at scene, or in the ED, if you started them warming up and they eventually went, all of a sudden they went into cardiac arrest, that is also a very bad prognostic factor. So to sum it up, remember that drowning is rare in developed society, at least in UK. It's common in developing countries, but it is still a significant cause of morbidity and mortality, because more than 5 minutes of submersion in water can lead to disastrous consequences. Most of them they would die even with the best treatment, and even if they don't die, the outcome would be so bad that the disability adjusted life years for these children who eventually make it up, but because they are disabled for the rest of their life, you can imagine they run into probably thousands of years. As I said earlier, the outcome mostly depends on the level of pre-hospital care. So if your paramedics system, ambulance system is good, they are well trained, and they can provide effective care at scene, that those kids, they do well. If not, the outcome is quite poor. Similarly, asymptomatic cases, those who had a little bit, like many times we in pediatric emergency, at least in my practice, I come across at least probably 1 or 2 cases a month where somebody brings their children and they say, oh, well, he was bathing, or we were giving a bath, and suddenly he slipped, and for a moment he went under the water, but then we immediately picked him up. So he choked, he coughed, probably a little bit has gone into his lungs, and he voluntarily coughed for some time, and then he was brought to the hospital. So we triaged them, everything is fine. I mean, the respiratory rate, SATs, GCS levels, and everything is fine. So these cases should be observed at least for 4 to 6 hours before being discharged. Because if anything has to happen, it would happen in the first 4 to 6 hours. If it doesn't happen in the first 4 to 6 hours, then usually the outcome is quite good. These should be kept for 4 to 6 hours if everything is fine, and then they should be discharged with the advice that if there is any problem like difficulty in breathing, cough, temperature, because sometimes the secondary, if there is sort of secondary infection risk or something, it would happen after 2 or 3 days. Tell them it after 2 or 3 days, he started having high temperature with a cough or difficulty in breathing, you immediately bring him back to the emergency department. In that case, you will do an X-ray to look if there are any X-ray changes, or you would like to find out if there is any alternative explanation for fever and cough and other things. Or sometimes you never know, somebody can pick up a viral infection as well later on. So, but again, it's a doctor's job to decide for these things, and that's how these cases are dealt with. So this was in a short about pediatric drowning and how pediatric drowning is managed at the pre-hospital level and in the pediatric emergency medicine department. And I tried to illustrate it with a case, with the help of a case study. Hope you have enjoyed this lecture. Please stay tuned for more lectures. If you like this video, please do subscribe and also press the bell icon so that whenever I upload a lecture, you get a notification. And if you've got any questions, please put them down in the comment section, and I would love to answer your questions. Thank you very much. Have a good day.